Welcome to Senadipin Education Foundation once again. Knowledge will bring you the opportunity to make a difference. We started this knowledge exchange program way back in 2007 by releasing our brochure. Actually, this is Antonio Longo, who is the founder of Stapler Hemorrhoidotomy, releasing a brochure in education program. And then we launched Senadipin Education Foundation in 2012, Jan 30th. And Sion Han Kim released launched the Senadipin Education Foundation. Then we were having 6 months and 1 year fellowship programs, which are hands-on in both the basic and advanced laparoscopy surgery. We had contact classes and hands-on training programs. With the advent of COVID, we changed the platform to online. And the first program was in June 2020. And the logo was released by none other than Dr. C. Palanivelu. And then we conducted live surgeries in online platform. The first FB live was in April 2020. That was a low anterior session laparoscopically. Then in August, we conducted a online program. Lab people was done live. Link was shared to the members of Senadipin Education Foundation, and then started live lectures with world leaders like Dr. Mathur. Recently, we started international fellowship programs in lab SPB surgery, lab colorectal surgery, and lab upper GS surgery in Japan, France, and Korea. The first batch was selected purely on merit. These are the name of the candidates who are selected for SCF International Fellowship Program for lab SPB surgery in Tokyo University Hospital under the guidance of Nagakawa Yuchi. And we have appearance in social media. In the first season, we had 28 webinars with world leaders like Nagakawa Yuchi. And this is on teach by Professor Ole Lingus, who gave a lecture in Senadipin Education Foundation in Jan this year. And it was attended by 1,400 delegates from 72 different countries. We have a YouTube channel. All the webinar videos are available in the YouTube channel of Senadipin Education Foundation. Last time we had a program with Professor John Windsor on acute pancreatitis. Today we are lucky to have Prof S.K.Mathur, who is a well-known leader, especially in SHUNT procedures. He will be talking on SHUNTS in 2022. He will be formally introduced by Professor POTTAKKAT. He is a senior consultant and GSPB surgeon in Sun Hospital. He was former professor of general and GI surgeries at GS Medical College and KM Hospital in Mumbai. You all know Professor BIJU POTTAKKAT is the professor of surgical gastroenterology, Jipmer, Pondicherry, India. As Mathur sir was mentioning, he is a great innovator and gives chances to his colleagues and he has got a lot of publications. Before going to the lecture purpose, all participants are requested to mute their mic. Actually, we had a mechanism to mute their mic on entry, but it's not working. I don't know why. If possible, kindly acknowledge by renaming your device by yours. And this is for especially for our counting in international fellowship programs. So you rename your device by yours. Participants logging from outside India are requested to reveal their identity in the chat box. Raise your hand if you want to intervene. We entertain one-to-one interaction. So anybody who wanted to talk to Professor S.K.Mathur or Dr. Biju POTTAKKAT, please raise your hand. We will be allowing you to unmute. Everybody will be given permission to unmute their mic on if you want. If you are on a portable device, please mute your audio and hide your video. If, you can write to us at sanadipin@gmail.com. With these words, I hand over the mic to Dr. Biju POTTAKKAT to introduce our speaker and to the proceedings.
Okay. Can I share the screen?
Please.
I think I need permission for sharing.
No, you are a co-host. You can share on your own. Just check. Yeah.
Screen visible?
Yeah, it's coming.
Good evening to all, and it's my pleasure and privilege to introduce Professor S.K.Mathur. And Dr. Mathur is currently working as senior consultant GI and HPV surgery at Zen Hospital, Mumbai. So he had a very illustrious career, which is still going on with a very strong academic and clinical front. He was a former president of Indian Association of Surgical Gastroenterology, former president of International Hepatobiliary Association Indian chapter, and he was chairman of several advisory boards, curriculum committees, member of several other expert committees, and he was examiner to several prestigious institutions, universities, and even abroad. And majority of his career was in as head of department of surgery and chairman of GS services at KM Hospital, Mumbai. And after his retirement, he worked at Fortis Hospital, Mumbai. So Dr. Mathur, two areas he had immensely contributed for our country and the scientific society and literature at large. One was he was very instrumental in establishing the setup related to organ donation in terms of laws and guidelines. He was member to several governments, mainly government of Maharashtra, and he is still serving as advisor to Rota and Soto. And he has more than 140 publications and several textbook chapters. And as you know very well, if you Google anything related to portal hypertension, Dr. Mathur's name will come in the first page of a search engine itself. So he has more than 50 publications, and what in our generation is a to Z encyclopedia in portal hypertension. That's what we used to call Dr. Mathur. And it is my pleasure, and I am highly privileged to invite Dr. Mathur to give a talk on SHUNTS in 2022. The title itself is self-explanatory. We don't know why it is to be discussed again in 2022. Welcome, sir, for this forum, and please proceed.
Oh,
Welcome, sir.
yeah. I will just share the screen and then start like so. Let's see. Is it moving? No, it is not moving. I'll just go to the other screen. Just a minute.
Yes, sir. Please make it a full screen, sir.
Yeah, that's what I'm doing. Just doing the. Okay. Just check. Yeah.
Yeah, now it's fine.
So yeah. So, Biju, thank you very much for that kind introduction. At the outset, I would like to thank BIJU first for inviting me for this prestigious foundation's educational program. As he mentioned in his coverage of the history, it's more than 15 years and more than 10 years for the webinar. And a lot of luminaries from the international world have addressed the audience on this forum. I always consider that anybody who indulges into educating others or creates a situation where he can educate the people not just by his own expertise, but also bringing the several people across the world, the experts, to educate the our colleagues. I think it's a tremendous work, and BIJU, I congratulate you and your foundation for doing such a work which I don't have words to describe. How I can say that what kind of good work you are doing. It will go a long way for the surgical fraternity in this country. And perhaps I've seen that people join from across the world. So it's an international education forum. Now, with that, I know that I've been given a topic which is very close to my heart, and the portal hypertension. And the reason for it is that actually this was a stepping stone for me to get into the liver transplantation. And I'm not talking about the liver transplantation today. We are talking about the searching for, are the surgical shunts relevant in the current era? And or is the shunt surgery the dying art? So we know that the variceal bleeding is the most dreaded complication of portal hypertension. And most of the therapeutic modalities are that's why directed towards control of variceal bleeding. We also know that the current evidence show that the pharmacological and endoscopic therapies control the variceal bleeding in majority of the cases. But we also learn from the published literature that the failure rates still remain high till the obliteration of the varices is achieved. And when the rebleed happens, some of them can be fatal. Historically, if you see, until 1980, the shunt surgery was the mainstay in management of the variceal bleed. However, in the 80s, with the introduction of the endoscopic sclerotherapy, the role of shunt surgery got reduced to a drastic extent. And in the 90s, with the introduction of the tips, which came as for the rescue of failure of the endoscopic sclerotherapy, the further the role of the shunt surgery went down. Now, this is the same phenomena which we saw at KM Hospital. Now, I would just like to give you the background that even before I joined KM Hospital in 81, there was late Professor Dr. Bhalerao, who was a pioneer in doing the portal hypertension surgery in this country, along with late Professor Vasu from Calcutta. And at that time, the surgery, as you can see from this graph, until 83, the surgery was the mainstay. In 83, we introduced the endoscopic sclerotherapy. And from there onwards, you can see while the endoscopic sclerotherapy as a management policy went up and the surgical interventions started coming down. Though from 90 to 2000, you can see there was slight increase in the surgical intervention, but basically it was for as a rescue therapy and few primary indications. I will allude to them subsequently. And it was rightly so, because this is what we published in after about 7 years of the and having experience with the endoscopic sclerotherapy using 3% icosaphenol, that endotherapy was highly effective. You can see the post-obliteration rebleed rate was low, 30-day mortality was less, and almost in 85% of the cases, you can achieve the obliteration, varicial obliteration. The problem was that before you could achieve the endpoint, reach the endpoint, there was almost 1/3 of the patients who will get the varicial rebleed. And this was similar to what was the published world literature at that time on endoscopic sclerotherapy. At that time, whatever the trials which were done comparing the endoscopic sclerotherapy with the shunt surgery, and you can see again, it is same reflection that almost 1/3 of the patients require surgery because of the failed endoscopic sclerotherapy. However, in 90s, with the introduction of the tips for management of the refractory varicial hemorrhage, today we have a scenario where we all know that we have very effective pharmacotherapy, endotherapy, and the tips. And in this scenario, we are searching for the indication for surgical intervention. So what I'm going to cover is what percentage of patients require surgery, what could be the indications in the current era, and this we will divide separately into cirrhotic patients and non-cirrhotic patients. And then for good risk cirrhotic patients, what is the evidence for tips versus surgical shunts? And then subsequently, I will deal with the non-cirrhotic portal hypertension. So, Biju will say that, sir, I have seen this slide several times. Yes, I have not added the numbers for quite some time. But if you see this in India, at least in 50% of the cases, the cause of portal hypertension is non-cirrhotic. However, the scenario is changing, particularly the centers which are majorly indulging into the liver transplant. The number of patients with cirrhosis, etiology, as a cause of portal hypertension has definitely will outnumber the non-cirrhotic portal hypertension. Now, out of this, till that time, 2007, 10% of the patients require primary surgical intervention. And I will allude to them, whatever the indication. And 23% were the patients who have failed endotherapy. So that was the rescue surgery for these patients. So first, let's see what is the role of shunt surgery for cirrhotic portal hypertension in the era of TIPS and the liver transplantation. Now, this was the article where I was co-author with Professor Bismuth when I was doing my fellowship in liver transplant with him in 89 and 90. And as per his experience, what the conclusions were drawn at that time, that for the patients should be primarily controlled with the endoscopic sclerotherapy. A child A patient is better served with the reduced size portable shunt because that is the preferred shunt in his unit. Okay. And for child B patient, it can be either sclerotherapy or reduced size shunts or the liver transplantation, depending on the individual circumstances. And child C patient, of course, should be managed by the liver transplantation. Now, this was at that time. So what with that time tips had not come into picture. And after 90s, with the introduction of the tips, today we have to look at what is the evidence of what should be done, whether it should be done tips or the surgical shunts. Now, I'm putting this basic slide here about when we talk about the evidence-based medicine. So if we are looking level 1 evidence, that is a randomized control trial, or level 2-1, which comes out from the non-randomized but well-designed control trials, and finally level 2-2, which is basically based on the cohort or the case control analytic study. So let's see how these two modalities fare on these evidences. So as far as the I will talk of the covered stent graph, not of the uncovered stent, because this is the current state of the art. And the last series, 550, definitely very effective in controlling the varicial bleed. Rebleed rate is low, but the problem remains high incidence of post TIPS encephalopathy. Now, with this, if we compare the historical results of shunt surgery, mainly DSRS for child A and B slot, again, rebleed rate is low. The advantage which appears is in terms of encephalopathy, because encephalopathy rate is also lower as compared to the TIPS. And same holds true for the reduced size portable shunts with the low rebleed rate and low encephalopathy rate as compared to the TIPS. Now, there is a large series which was published with the DSRS in 2005, and you can see they looked at the child A, B, C separately, and they looked at the survivals at 5 years. So you will see that for child A, it's and low milder patients, the survival is to the tune of 40% of the patient will survive at least 5 years before they go for the transplantation. Now, if you look at the studies which are case control study, okay, and that is, and here, if you find that TIPS has been associated with significantly higher incidence of rebleed, rehospitalization, shunt revision, and more expensive as compared to the DSRS. Now, this was a randomized control trial conducted by one of the disciples of De Warren, that is Anderson, and which compared the DSRS with the TIPS. The conclusion was that both of them are equally effective. However, the reintervention rate was significantly higher for the TIPS, and there are no difference in the need for liver transplantation. So the conclusion was the choice is dependent on the available expertise. That means one can use the shunts DSRS or one can do the TIPS. However, another randomized prospective control trial with 10 years follow-up published by Rosemorgib, and which compared the reduced size portable shunt with the TIPS. And that showed that, yes, the mortality was higher in child C patient, but the rebleed rate and the shunt stenosis rate and the encephalopathy was significantly less for the reduced size portable shunt compared to the TIPS. And they also showed that survival at 5 to 10 years was superior after reduced size portable shunt compared with the TIPS for child class A and B. And this is what is important. And those patients with a low MELD score. Now, they also looked at what is the need of liver transplantation, because we know when the TIPS is usually used as a bridge to the transplantation. So in their series, the 9% patient required TIPS versus only 1.5% following the reduced size portable shunt. Now, there is another study which has looked at that what is the incidence of liver transplantation requirement after doing the DSRS. And if you see that, this shows that at least 13.5% patient underwent liver transplantation after a mean of 5.1 years of DSRS. And what they also documented that compared to those without prior DSRS, there was no significant impact on duration of surgery, use of blood products, or the 30-day mortality. So a DSRS doesn't really make the subsequent liver transplantation more difficult. So according to this study, if you look at the DSRS may be considered first-line therapy for recurrent variceal bleeding in patients with childhood class A and early B who have failed the endotherapy and who are unlikely to undergo the transplantation within next 5 years. Now, this rider is very important. That means these are the good risk patients who are not a transplant candidate at this time. And now there's another study which showed the effect of DSRS on the portal flow. And this shows that when you compare with the TIPS, the portal flow remains high, while the DSRS group, the portal flow goes down, because that's quite obvious that the blood flow which is coming from the spleen has gone down. And this is what is used in the liver transplant to counter the small font size graft syndrome in the LDLT settings. And so perhaps the DSRS done prior DSRS may help in those patients who are subsequently going for LDLT in avoiding this small font size graft. Now we look at the more recent evidence. Now this is the AASLD practice guidelines published in hepatology in 2010. And there are two groups, one which compares the endotherapy with the portable shunts, and the second is endotherapy with the tips. If you look at the terms of the rebleed, definitely both the portable shunts and the tips are better than the endotherapy. In terms of encephalopathy, naturally the encephalopathy rate is lower with the endotherapy, but also encephalopathy rate is less in surgical shunt group versus the tips. The mortality with any of the therapeutic modality remains same, and that is because in the cirrhotic patients, unless that liver goes out, liver transplant is done, the mortality is determined by the hepatic reservoir state of the liver. So this again shows that naturally the surgical shunts are superior to the tips. So when we talk about evidence-based medicine, okay, and so if you look at all what I presented so far, what the evidence says, the evidence-based conclusion should be for child A and B patients with a low MELD less than 13, the surgical shunts have a role, whether it is DSRS or reduced size portable shunts. And for high-risk child C patients, the tips should be used as a bridge to the transplantations. Now, from the cirrhotics, we come to the non-cirrhotic portal hypertension, which is a common cause of portal hypertension in our country and some other Eastern Asian countries. Now, here I would like to divide these indications for surgery into two. One is the variceal bleed-related indications, and second is the other indications which are more related to the, which are more peculiar to the NCPF and the EHPBO. So in this, again, I'll divide the indication. Is there a role of primary surgical therapy in these patients? We know about the rescue therapy. We'll talk about that later. So for me, if the patient has got spleen-related problems, that is either severe hypersplenism, symptomatic splenomegaly, or growth retardation, endotherapy is not the answer, and the shunt surgery is the answer. So that becomes a primary indication for elective surgery in this situation. Now, I'll just allude to what I call it a hyperspleen, because we know that the pancytopenia is very common in patients with the portal hypertension. However, the patient should have symptomatic hyperspleen, which is indicated by white cell count lower than 2,000, platelet counts less than 50,000, and manifested by either recurrent episodes of sepsis, spontaneous bleeding, or anemia in absence of GI bleeding. And that incidence is, at least in my series, was only 7%. So it is less than 10% patients will require surgical intervention because of the hypersplenism. Yes, a large spleen causing dragging pain, visual lump, discomfort to the patient becomes an indication for surgery. Now, growth retardation in the children in the EHPBO has been documented by Dr. Sareen and by Dr. Yacha from SGPGI Lucknow. And for me, the incidence is not as high as it is shown here, because the child growth is a linear growth. It doesn't happen at one point. Children can grow suddenly, they can get the growth spurt in after 10 years or 15 years, and you might say that they may grow to the normal height as per their family background. So that incident, but yes, if the growth retardation is the problem, it is the indication for surgical intervention. Now, from spleen-related indication, we come to the other indication. And here, the portal biliopathy or the biliary obstruction by the portal cavernoma. And this is the MRCP, which is showing the structure in the mid CBD and in the left hepatic duct. And this is the MR portogram showing the portal cavernoma. And this is the overlap of the MR portoimmunogram and with the MRCP. And you can see how the cavernoma compresses and cause the biliary obstruction. Now, majority of these patients are asymptomatic. It is only, or they may present just with the abnormality of the LFT, with basically the raised ALP or GG2. However, those who become symptomatic, they either present with the recurrent jaundice or biliary colic, which is the biliary calculi, or recurrent cholangitis, or combination of all three. Now, once they become symptomatic, the initial treatment is endoscopic therapy, which is by sphincterotomy, endoscopic stone extraction, and biliary stenting. However, it is sometimes associated with massive bleed and requires emergency surgical intervention. So it should not be done at a center where all the facilities, surgical facilities are not available. The shunt surgery plays an important role because most of these patients are young and you cannot commit them for lifelong endotherapy. And here the shunt surgery is used to relieve the biliary obstruction and to facilitate subsequent bile duct surgery. And here I would like to quote this article published by Dr. Adarsh Chaudhary, and which is very true, that if you try to do direct biliary surgery before the shunt surgery, it can be hazardous, it can lead to profuse bleeding and result in the mortality. And what he recommends is the first do the portosystemic shunts, wait for 6 weeks, and then do the biliary surgery if indicated. Now, if you look at the various series published, including our own experience, in fact, the portosystemic shunt itself is sufficient to take care of the biliary obstruction in almost 70% of the cases. The only 30% of the patients will require subsequent biliary surgery. And then this, because the portal pressure has come down and the collaterals have collapsed to an extent, the biliary surgery also becomes easy. Now, the other indications for primary therapy, the surgery as the primary therapy, are the bleed from the ectopic varices, whether it is ileal, jejunal, colonic, or rectal, which are not amenable to the endotherapy. And then second is the gastric varices. Now, here I will start with showing the classification of the gastric varices for the simple reason that the first classification came from Hoskins, published in 1988. And at the same time, we also published, subsequent to this article, our classification of gastric varices in Journal of Gastroenterology and Hepatology. And this was followed by the publication from Dr. Sareen. Now, why I feel that this classification and Dr. Sareen's and what is adopted by the Bevino is little different, and why I think that this is more applicable as to when we talk about the therapy. And this particular differentiation comes here. One is when we talk of GOV2, that is subcardiac varices, what one can have along with the esophageal varices, large diffuse fundal varices. So that one has to differentiate because they don't behave similar way. Same thing when we talk about the IGV, isolated gastric varices. Yes, commonly they are associated with the splenic vein thrombosis, but when they happen secondary to generalized portal hypertension, okay, then they have to treat it as generalized portal hypertension, not as the isolated splenic vein thrombosis. So one has to differentiate with these two subclasses of isolated gastric varices. And then there are patients who have a combination of both lesser curve gastric varices and diffuse fundal varices, and lastly the enteral varices. So if we look at this, the lesser curve gastric varices, they get usually obliterated with the endotherapy of the esophageal varices or respond very well to the sclerotherapy. The subcardiac localized varix can be very well managed with the cyanochrolide glue injection. The antral varix hardly ever bleeds. We have published the article on this. And if at all they bleed, they can be controlled with the endotherapy. The problem is these diffuse fundal varices in association with the esophageal varices, which we call type 2B, and the isolated gastric varices with and without splenic vein thrombosis, and the type 4, which is a combination of lesser curved gastric varices, esophageal varices, and the diffuse fundal varices. So this isolated gastric varices. Now, I will just tell you that when it is association with the isolated splenic vein thrombosis, the treatment is just splenectomy because this is a curative. And I always say there's only one type of portal hypertension which can be cured by surgery, and that is the left-sided portal hypertension. But when the diffuse fundal varices are in association with the generalized portal hypertension, that means the splenic vein is patent. It is the obstruction is towards the liver, whether it is ESPBO or NCPF or cirrhosis. In these patients, if there is a bleeding, it should be managed with the splenomedullary shunt, not just with splenectomy. And that's why you have to divide them into. Now come to these large fundal gastric varices, whether isolated or in association with the esophageal varices. The incidence is less, but when they bleed profusely. Now, we know that the glue injection is very effective in controlling the initial bleeding. However, the problem is the late bleed, which happens in almost 50% of the cases. And apart from the low incidence, the incidence of the fatal complication because of the glue embolization. Now, this is a series with a long-term follow-up with the glue injection came from Japan. Again, it shows same thing. The almost 50% of the patients continue to rebleed after the cyanochrolide glue injection. And what they concluded that the historical injection is highly effective for treatment of bleeding gastric varices. However, because higher rate of recurrent bleeding, it is advisable to develop alternative therapy for controlling the gastric varices. Now, this is my own patient who undergone multiple sittings of the cyanochrolide glue injection for controlling of the recurrent gastric variceal bleeding. And you can see the cast lying into the splenic vein. So when this patient continued to bleed and came to us in emergency, it was a nightmare to operate. The shunt was not possible. You can see this whole axis is gone. Patient had EHPBO. And then the stomach, there was deep ulcer adherent to the tail of the pancreas and the spleen. It was a hell of a job even to do the devasculation in this patient. Now, what is the effect of the tips on these gastric variceal bleed? Now, multiple studies have shown that FGB failed to resolve with the tips at least in 20 to 50% of cases. So it is not completely effective in controlling the bleed. So almost 20-50% patient will require surgical intervention. Now, what about the management with the BRTO? Yeah, it is very effective for the benefit of the audience. I'll say that the BRTO is basically done by the interventional radiologist, a transfemoral approach, a natural shunt between the splenic vein and the renal vein. The left renal vein has to be there to use this technique. One goes to the left renal vein, goes into the collaterals, inflates the balloon, and then injects the esclorants and keeps the balloon there till for some time, so that for the esclorant to have the effect on those and block the shunts. Now, this study which compared the tips versus BRTO for diffuse fundal gastric varices bleed. You can see the bleed rate is less with BRTO as compared to the tips at 1 and 3 years. And of course, the post-procedural hepatic encephalopathy is not there with the BRTO. So naturally, BRTO becomes the therapy of choice if the patient has got a natural shunt for control of the gastric variceal bleeding over the tips. But BRTO has its own problems, and that is it aggravates the esophageal varices. And the worsening of the esophageal varices bleeding, which happens in almost 63% of the cases, and the worsening of the portal hypertensive gastropathy, and it aggravates sometimes the ascites and then leads to the formation of hepatic hydrothorax. So for me, the best treatment for these patients is the surgical intervention. Here's the example of a patient who had isolated gastric varices in just part of generalized portal hypertension, didn't have esophageal varices to begin with, multiple sittings of the endotherapy, that is using the glue injections. Subsequently, you can see the esophageal varices also develop. These varices continue to have rebleeds, and finally we did the DSRS in these patients, and you can see both the esophageal varices and the fundal varices collapsed. And there the rebleed rate is less than 2% with the surgical intervention. So from here, we come to the rescue therapy. Okay. So if you look at the options for rescue therapy in non-cirrhotic portal hypertension, again, I say surgery is therapy of choice, not the TIPS, because in extrahepatic portal in thrombosis, TIPS is usually not feasible, though in the Western world, they are showing some patients where they can put the TIPS and de-obstruct the portal vein in some percentage of the cases. For non-cirrhotic portal fibrosis, the liver is near normal, and the risk of encephalopathy with the TIPS is not acceptable. And that's why one will like to do the surgical intervention. And here, for the benefit of the audience, I would like to show that what is the natural history of the liver functions in patients with NCPF versus cirrhosis. You can see this cirrhotic liver, the nodular formation, shrunken liver versus NCPF liver, which is not nodular, not shrunken. Okay. In both the cases, it is intrahepatic obstruction. There is definitely progressive decrease in the portal perfusion, but it is more marked in cirrhotic versus non-cirrhotic. So a cirrhotic patient ultimately die of liver cell failure with a decreased lifespan unless rescued by the liver transplantation, while the NCPF patient has got a near normal lifespan. And so we should not do anything which will decrease the portal perfusion. As far as the EHPU is concerned, the portal cavernoma maintains the portal perfusion, and they have a normal hepatocyte function till date, and then that's why they have a normal lifespan. So in both these cases, our aim should be to effectively control the variceal bleeding without causing any adverse effect on the portal perfusion. Okay. So coming to what are the surgical options, and I'm restricting myself to the shunt surgery, not to the transplant and the non-shunt surgery or devasculation procedure. So we have the total shunt, we know all that, porta cable, proximal linear, side-to-side linear, mesocable, makeshift shunts, and we have a selective shunts, mainly the Warren shunt. The coronal cable Inokuchi shunt has never been practiced outside Japan, and not now after the death of the Professor Inokuchi is being practiced even in the Japan. Reduced size porta cable shunt as popularized by Safe, we'll talk about that. And finally, for EHPVO, what is the role of REX shunts? So again, we come back to what is the choice of surgical shunt for non-cirrhotic portal hypertension. Issue is it one procedure for all patients or different procedure for different patients? And then how to make the choice. So planning of the shunts depends on three factors: the etiology, the available venous anatomy, and the indications. And ultimate aim is to decompress all symptomatic varices, and for that we might have to modify the shunt. So if you look at the etiology-wise, what we are looking at the outcomes of different shunt surgical procedure according to the etiology. And I'll take the NCPF first. And as per the world literature, we see whether it is total shunt, whether it is the porta cable shunt or spinal shunt, or the selective shunts, or the non-shunt operation, all are very effective in controlling the variceal bleeding associated with the low rate of TB. Now, what differentiates these procedures? The porta cable shunts and the spinal shunts have got higher incidence of encephalopathy as compared to the selective shunts or the non-shunt operation. So naturally, on this basis, the choice will be one should be doing either the selective shunt or the non-shunt operation. If you look at the Indian scenario, the published series for NCPF, again, late Professor Basu series with the POTTAKKAT shunts, and then he did the selective shunts. He switched over for NCPF patients because the high incidence of encephalopathy with the POTTAKKAT shunt to the selective shunts. Professor Nandi's series and the Professor Basu series with the proximal splenic shunt again showed a high incidence of encephalopathy, though clinically significant encephalopathy was compared to the less. Now, this is a recent publication which came from AIMS, a large series of 272 patients. Again, you see the after proximal splenic shunt for these NCPF patients, the 13% incidence of encephalopathy. Which, to me, a patient with the NCPF, I won't accept it if I am the patient. So for me, for NCPF, the choice should be a selective shunt because they maintain the portal flow to the liver, less incidence of encephalopathy, and of course, it preserves the spleen, which avoid the post-splenectomy sepsis, though the incidence is low. When we come to the extrahepatic portal venous obstruction, now this is the privileged class. Here, whatever you do, so long it is effective in controlling the rebleed, whether it is proximal shunt, whether side-to-side shunt, DSRS, or the modified figures, all are effective, but there is no encephalopathy. So the choice depends on the expertise of the person, and you can use any of the surgical procedure for these patients. And if you see the Western literature, again, they have shown the shunt surgery, which is proximal shunt surgery. Again, rebleed rate is low, and there is no encephalopathy. Marshall Orloff published his series of 200 patients of EHPBO with 3 types of shunt, that is the side-to-side shunt, proximal splenic shunt, and the mesocaval shunt with good survival, and again, no encephalopathy. Again, driving the point that for EHPBO, you can use any type of shunt, whatever your expertise allows and whatever the venous anatomy allows. A word about the REC shunt, which is basically not a shunt, it is a mesoportal bypass, very effective and shown to decrease the splenic size, hyperspleen growth impairment. And the conclusion is that this is the way to deal with the patient with the extrahepatic portal venous obstruction. However, when I look back at my the splenoportograms and the current CT portogram, the problem is in Indian settings, we hardly find a venous anatomy which is suitable for this REC shunt, because most of our cases are secondary to the umbilical vein sepsis, and which leads to obliteration of the left branch of the portal vein. And that's why the patients are not suitable for the REC shunts. Another CT portogram, you can see the condition of the left and right intrahepatic portal vein. So they are not suitable for the REC shunts. Now, having covered that etiology part, we come to the how you decide the surgery according to venous anatomy and the indication. So when this is the CT portogram, you can see this is an NCPF because you can trace the portal vein radicals right up to just short of the capsule. And the vein is quite straight. This is the coronary vein, the retrogastric veins forming the fundal varices. It is quite straight. So it's very suitable for doing the distal splenorenal shunt. As seen here, this is the splenic vein and this is the renal vein, and this is the portion basically gram to show the patency of the shunt. So for DSRS, a specific indication will be NCPF, as I said before, that is selective shunts, maintains the post-groid blood flow, and so less incidence of encephalopathy. When the bleed is mainly from fundal gastric varices, again, DSRS provides the direct decompression of these fundal gastric varices. So what are the problems with the DSRS? The problem is the technical challenge. The less people are well versed with the technique of doing the shunt. They think it is a difficult shunt to do. I will try to show the small clipping of the DSRS that toward the end. It is said that a large spleen comes in the way, and of course, uncontrolled ascites is a contraindication, but not massive splenomegaly. And this picture is to show that here is the spleen which is kissing the liver. It's a large spleen, and once the DSR is run, you can see on table the spleen shrinking. So a large spleen is not a contraindication as is being traditionally taught. Yes, portal biliopathy is a contraindication for DSRS because DSRS is very specific for decompression of the left-sided system, not the right-sided system, which is the portal cavernoma here, which is responsible for the portal biliopathy. Now, from here, we come to the concept of partial shunts. It was introduced by Bismuth in 1974, but he used the vein-to-vein reduced size shunt, and the veins dilate over a period of time, so the selectivity get lost. It was Survey who revived this concept of incomplete decompression of the portal system, thus maintaining the portal perfusion. And what he used is the ring-supported PTFE graft, and the principle is that the diameter of the graft should be 50% of the diameter of the portal vein. It has to be anastomosed at a particular angle, and then it remains patent because the force of the blood keeps it patent. The incidence of thrombosis becomes less, and it also maintains the prograde flow to the liver. And if we look at the results, the results of the partial shunts and the DSRS are both showing low encephalopathy rate and good variceal control. Now, when the problem is spleen related, of course, there is no choice but to do the splenectomy, and then it has to be combined with the proximal splenial shunt. Now, when do we do the side-to-side splenial shunt? Basically, when the splenic vein size is small, and one has to decompress both the splenic site and the mesenteric site. That means the patient has got both the portal biliopathy as well as the patient has got the gastroesophageal large varices. In that case, one can do the side-to-side splenic shunt. In this country, you should remember that Prof S.K.Mathur had been main proponent of this shunt, and should, particularly for children with EHPBO. The most important part is that a renal vein and the splenic vein should be in close proximity and overlapping. So the anatomy has to be looked into before attempting the side-to-side splenial shunt. Now, where will be the indication for doing a mesocable shunt? For me, indications are if there is a previous splenectomy done wrongly or rightly, if the proximal splenial shunt gets blocked and the patient comes back with the rebleeding or with the portal biliopathy, for patients with the Budd-Chiari syndrome, and if the portal vein and the splenic vein both are thrombosed, in that case, you have no choice, and the SMV is present, the patent, then you will do the mesocable shunt. And of course, for ectopic varices, a mesocable shunt may provide a direct decompression. Sorry. Now, from this indication, according to venous anatomy and etiology, we come to how do we achieve complete decompression of all the symptomatic varices. And here I will give you the example that how sometimes we have to modify the shunt to achieve that. Now, there's a case here, you can see actually one of my ex-colleagues was operating long back in KM days, and he wanted to do the Warren shunt while dissecting the splenic vein. There was a problem. He couldn't dissect it, and there was a tear, and I was called in to rescue. And what I did was, at that time, because the splenic vein was badly embedded into the pancreas, and so I looked at the adrenal vein, which was dilated, and anastomosed it to the side of the splenic vein. And that's where we started doing these cases using the adrenal vein as a conduit to do the splenic vein. So it becomes a splenial side-to-side splenial shunt, but it makes the surgery easy. And since then, I've used it several times. So definitely, when there's difficulty in dissecting the splenic vein and there's a dilated adrenal vein, one can use it for doing the adrenal shunt. Now, sometimes there's difficulty, but the adrenal vein is not dilated. What do you do? In that case, one can use this technique I learned from late Prof S.K.Mathur, that you can divide the renal vein onto the renal hilum, just little away from the renal hilum, so there is a venous drainage for the kidney as well, and anastomose the end of this renal vein to the side of the splenic vein. Now, sometimes it happens that the renal vein, venous anatomy is abnormal. And this, I was caught, it was surprise for me that when we wanted to do the Warren shunt and we were not finding the renal vein in its normal position. And finally, we found that the renal vein was actually low down opening into the IVC. And there was no way I could have done the Warren shunt. So what we did again, we did the end renal vein and the splenic vein and did the anastomosis. This is just the innovation done on the cable. Now, here are the patients who presented with the portal biliopathy, but also had large esophageal varices and large fundal varices. And when we did the CT photography, what you see is you can see the proximal part of the splenic vein, which is patent, middle part is missing. You can see the SMV and there is a IMV here. Now, the issue is, if we want to decompress only the portal biliopathy, yes, one can do the musical shunt, but then he has also got the large gastroesophageal varices, which will remain undrained. So how do you achieve in that case? So what we did, you see this in second reconstruction. This is the splenic vein, this is the renal vein, and we have got the inferior mesenteric vein coming here. So what we did was I used the adrenal vein again as a conduit to join to the splenic vein here and use the inferior mesenteric vein. It divided here and swung it to the side of that adrenal vein and thereby creating this Y-shaped shunt. So this is the IMB coming to the side of the adrenal vein, this adrenal vein going to the splenic vein and the renal vein here in the background. So you have to innovate sometimes depending on the venous anatomy and the indications. Now, I would like to also emphasize that sometimes there are complications with the DSRS. It's not there are no complications. One of the things which have been described in the literature is the pancreatic siphon or the steel phenomena, which can lead to encephalopathy. This is described by the Warren himself in alcoholic cirrhotic patients, and he advocated extensive splenopancreatic disconnection. However, in one of our patients of NCPF, where I've done the Warren shunt, after 3-4 years, he presented with the mild encephalopathy. And when we did the gram, we found that there was a steel going through you can see these collaterals through the pancreatic bed, and that was causing steel onto the main portal system through the shunt. And what we did was the coil embolization of these collaterals rather than doing the second surgery, and that controlled the encephalopathy. Now, sometimes you observe that there is shunt stenosis in the post-op period, then your intervention radiologist comes to the rescue by doing the balloon dilatation. Now, this was another patient who Warren shunt got blocked. Patient had esophageal gastric varices, which started bleeding. And here the Sudeep came out with the Sudeep Shah, who had been my resident in the past. He is a big consultant now in the Hindu Hospital, Mumbai. And he came out with the idea that why don't we embolize the splenic artery? And it worked actually for this patient, and the bleeding stopped because this behaved like a left-sided portal hypertension now. There are another complications seen in the post-op period. Patient developed collection in the peripancreatic area, which turned out to be the big pancreatic pseudocyst. The options were whether to bathe, watch, or octreotide. And what we got it done was the transgastric endoscopic drainage, and that took care of this unusual complications of the Warren shunt. So to conclude, yes, today we cannot deny that endotherapy is the highly effective therapy and will remain so. But the problem is it needs a lifelong follow-up, and there is a high incidence of pre-obliteration rebleed rate, which nobody had is unable to take care of. So in this scenario, what are the choices, therapeutic choices? The surgery is the therapy of choice when there is bleed from ectopic varices or diffuse fundal gastric varices, when the indications are spleen-related, where there is a symptomatic splenomegaly, symptomatic hyperspleen, or there is an issue of growth retardation in the children, or there is a portal biliopathy in the young patient with the EHPBO. For cirrhotic good risk patients, yes, evidence says one should do the surgical shunt, not the tips, but the practices are different. Today, hardly anybody will subject a cirrhotic patient to the Warren shunt or the Zulu shunt. They all will go for the tips and the transplantation. Of course, the poor risk patient should go for the tips. For non-cirrhotic patients, I think one should look at the shunt surgery. This is an algorithm which I made long back, but it holds true today. Also, the cirrhosis child A and B and good result should be by, as per evidence, should go for DSRS surface shunt. Poor result, they will definitely go for transplantation. Child C patient as a rescue therapy should be managed with the tips. Only patients where the tips is not unavailable or unfit for liver transplant, they are not transplant candidate and bleeding profusely. In that case, I've done sometimes the devascularization. As far as the non-cirrhotic portal hypertension concerned, NCPF patients were suited by the selective shunt or the partial shunt. And yes, modified Segura gives the equally good results. As far as the EHPBO is concerned, if the venous anatomy is suitable, yes, one can do the rection, which is the preferred bypass today. Depending on the venous anatomy, one can do either mesocaval shunt. If the splenic vein is patent, then a large spleen is the issue, one will do the splenectomy with proximal shunt. If that is not the issue, then one can do the either DSRS if the issue is basically bleeding from the fundal varices, or the side-to-side splenic shunt. If the EHPBO complete splenoportal axis is blocked, splenic vein SMV is not available, then one will resort to the modified Segura operation. So, to me, in portal hypertension, no single surgical procedure is ideal for all patients for all circumstances. One should choose the surgical intervention according to etiology of the portal hypertension, timing of surgery, what is the portal venous anatomy, what is the indications, and of course, what is the available expertise. This is the map of India and the Mumbai. This is for the foreign audience, and this is the institution, that KM Hospital, where I spend most of my time doing the work on the portal hypertension. And these are all the people who suffered at my hands because of my unit was all the times, means all 7 days, entire year, 24 hours on call for the patients of variceal bleeding. Subsequently, when I moved to Nair Hospital, these people were my resident there. They all be consultant now. And when I moved to the Bombay Hospital, they joined me. Some of them came to work with me and saw the portal hypertension surgery. And this is my last batch of the GI surgery, DNB GI surgery resident from Wokhart Fortis Hospital. And this photograph was taken 2013, and who were missing in those previous photographs are Dr. Supe, Dr. Abhay Dalvi, Dr. Chetan Kantharia. They all became now big people. He retired as a dean. He just retired as a professor of surgery at GS Medical College. He's currently head of GI surgery. Dr. Pramesh, who heads the Tata Memorial Hospital. Dr. Mahesh Goyal, who is head of the hepatobiliary work at the Tata Memorial Hospital. Dr. Bhalia Kulkarni. He has not followed in the academic medicine. He's settled in Nashik, but he assisted Dr. Bhalera, both and Dr. Abhay Dalvi and Dr. Dev Balya Kulkarni were assistant to Dr. Balya before they came to work with me. And then, of course, Dr. Sudeep, and currently it is Jain Hospital Chief, entrepreneur, excellent laparoscopic surgeon, Dr. Roy Pattakkat. And then there are these two chaps who worked as a resident with me, Dr. Sunil Singhal and Dr. Doke and Dr. Sunil Sate. So I'm thankful to all of them for helping me in reaching to this stage as far as the port hypertension surgery and other surgical things concerned. Thank you very much. And I will end this and stop sharing my screen. Biju, there's a 4-minute clip of the DSRS. If the time permits, I can show it. Otherwise, we can take the questions.
Thank you, sir. You can proceed with the video, sir.
Okay. So this is without the commentary. Okay. So this is distal splenial shunt. You can see this patient, they've got a spleen, large spleen, and this is going pushing the liver. Now, first dissection is in the infracolic compartment. You have to dissect the splenic vein out of the pancreatic vein. And I used to use this hydrostatic dissector. And you can see these are the pancreatic tributaries, which have been ligated and divided, and that mobilizes the splenic vein out of the pancreas. I usually use a pointed tip mixture for right angle for isolating and ligating them. Today, with the availability of the modern energy sources, you can use the bipolar or the other thing. Then goes to the retroperitoneum to dissect the renal vein, and you can see the, just a minute. Sorry. So adrenal vein, gonadal vein, and the main renal vein, and that is the splenic vein. Then we divide the splenic vein towards the portal vein side and close the splenic stump. And and this is the splenic vein. End of it is associated is anastomosed to the side of the renal vein. You can see this is the satin clamp on the side clamp on the renal vein. So the posterior layer suturing is continuous. If the vein size is 1 centimeter or more, even anterior layer is continuous. But if the vein size is small, like less than centimeter, then anterior layer, usually I take the interrupted suture. So this is the posterior wall suturing is over, and then you can see that corner stitch being taken. Usually I use the 6-0 proline for this. I don't, I haven't used the loops throughout my life. Not that I am against the loops, but I could manage with when I was not using the specs. Without the specs, once I started using the specs, I could do it with the specs on. So now you can see the anterior layer of the continuous suturing. Then I will show you a clip from another, it is incorporated in this, which will show the interrupted suturing. So now I'm showing the interrupted sutures, the part of the anastomosis. The important part is the distance between these sutures has to be precise. Usually it is 1 millimeter. This, when we open this temporary release the clamp, you can see from the renal vein side. The clamp is in place, but it's just give the back bleed, see the bleeder, then inject the heparinized saline in the vein to avoid any clotting. And once the last stage, when we take the growth factor, which is given for expansion of the renal vein. And now you can see the renal vein clamp is removed first, and this will be followed by opening of the splenic vein clamp. And now, one thing you should notice here, the lie is not a good lie. You can see they are almost running parallel. They should come at the angle, and I will show what I did to. This is because of the excessive mobilization of the splenic vein from the pancreas. Now, during the surgery, I always put a clamp on the splenic artery to prevent the congestion. Now, you will see that I'm taking a stitch through the wall of this splenic vein and fixing it back to the pancreas. Okay, and now you can see the lie has changed. It is a smoother lie in compared to the previous when it was running parallel like this. So one should avoid this, otherwise the chance of shunt over there. Now this is what I wanted to show, that the large spleen like this, and on the table you can see it shunt. You can see the stomach was not seen, that is seen. So that's the end of this video, Biju, and I will stop sharing.
Thank you, sir. You will not get a better person than you for this wonderful talk on SHUNTS in 2022. We are really blessed to have you in this forum, sir. I hand over the mic to Biju POTTAKKAT to conduct the proceedings.
Thank you very much for the wonderful and detailed lecture. We'll just discuss 2-3 issues very quickly.
Yeah.
One is because of the very long decades of conservative management for the variceal bleed, you get patients of NCPF coming back to you with multiple problems, including hypersplenism. So some of these patients may already landed up in child A cirrhosis, which we call NCPF-related cirrhosis.
Yeah.
Want to know how will you approach this patient? Is there anything different or the same?
Yeah. So see, if a patient, even for cirrhotic, the evidence is that child A patient is not a transplant candidate. Okay. So child A NCPF is not a transplant candidate because he still can be managed if the variceal bleeding is the problem, if the hypersplenism is the problem, if you decongest the portal system, okay, then they will have a life which is longer before they actually go into the transplant. Yes, some of them will advance that cirrhosis, that NCPF damage is so much that the fibrosis will advance to the cirrhosis, what we call the nodular NCPF, and they will again, in that stage, they will decompensate. And once they decompensate, yes, the liver transplant is the only choice. But before they decompensate, if we put the tips, then they will be pushed towards the transplant. And that's why if it is child A, even NCPF developing early cirrhosis, and it's a failure of the endotherapy or pharmacotherapy, I will prefer a selective shunt, as a Warren shunt particularly.
Okay, sir. Thank you. Second issue is many of the patients with NCPH, although planned, may end up in splenectomy because of actual reasons or induced reasons.
Mm-hmm.
So, for the benefit of the audience, can you please explain what will be the exact effect of this splenectomy only for this subgroup of patients?
Yeah. So one thing one should remember, that once you do the splenectomy in a NCPH, you are not done anything to the portal hypertension, except that some people believe that the spleen the itself contributes to the rise in the portal pressure. Yes, it does contribute. It's not that it doesn't contribute, but that contribution is much smaller than the resistance offered by the liver or resistance offered by the cavernoma. So the portal hypertension persists. In that case, this patient will have a problem in the future, and you have lost the opportunity of providing a proximal splenomeninal shunt, because now the spleen vein will get thrombosed. And if by chance that patient doesn't have superior mesenteric vein patent, it will be a difficult to accept doing the devascularization in the future. And that will also be a difficult surgery because already splenectomy has been done in that area. So that's why I feel that if at all splenectomy is indicated in these cases, okay, because of the hypersplenism, all that thing, spleen-related issue, one should combine it with the proximal splenomeninal shunt.
Before the next question, Biju, Dr. Abhay Dalvi was proudly telling in the chat box that he is a disciple of Professor S.K.Mathur, word from Dr. Abhay Dalvi.
Yeah, good evening. I'm really happy to hear, sir. I have been associated with portal hypertension since '82 when I did my 6 months of house post under Dr. Balerao. I distinctly remember doing 17 shunts, and I used to wonder, how patients live with these shunts. But the time that I spent with Dr. Mathur from 1986 to 1991 as assistant professor under him, he introduced endoscopy, sclerotherapy with 3% phenol in water, which is a pioneering effort according to me. Still, we continued to do shunts, and I learned a lot from him. Timely decision, timely interventions, and what to do at a particular thing, especially in portal hypertensions. Keeping records of all these patients that sir has shown has been my headache through these 5 years, as I can see, and still he has the records. Sir, thank you for whatever you have done for me through the years, and actually seeing me again coming up as a laparoscopic surgeon. Thank you so much, sir.
Thank you, Abhay. As I mentioned in my lecture, the journey of portal hypertension, liver transplantation, or the other liver sections and all that thing would not have been possible without the very able support from all of you. Okay. I remember that when I came back from my training in liver transplant, and I used to write from there, you go to the dog lab and start doing how to do the hepatectomies and keep these things ready. And the moment I landed, and within a week time, we started doing the dog experiment of liver transplantation. I'm sure you will remember that.
Yes, yes. Much obliged.
Thank you very much for those kind words.
Yeah, for the international audience, just want to introduce that Dr. Abhay Dalvi is the immediate past president of the Association of Surgeons of India, the largest body of surgeons of India, more than 25,000 members, and he's an active member and executive committee member of AMASI, very active in the field of minimally invasive surgery. Thank you very much, sir, for your comments. The next question, there are multiple questions related to post-op anticoagulation protocols after shunt surgery.
What that?
Sir, post-op anticoagulation, do you give? And if you give, what is the protocol?
Yeah. So see, one thing is that 1 dose of heparin given before we clamp everything, all the splenic vein and the renal artery or splenic artery. Then usually for 10 to 14 days is the protocol. And nowadays we use the low molecular heparin. Otherwise, I used to use the conventional heparin, and usually it's 5,000 units BD was the dose which we use as a thromboprophylaxis, but only for the period of 10 to 14 days. Now, as you know that in India, the cause of EHPBO is not hematological or the hypercoagulable states. And that's why we get away with this type of protocol. And that's the same, I think, experience with at the AIMS also. They also don't use the prolonged anticoagulation for these patients.
Okay, related question, sir, is do you do bone marrow biopsy workup before shunt surgery in NCPH?
Not really, not always, unless there's a definite indications. See, sometimes what I've seen both in NCPF and EHPBO, and I don't have an explanation for this, is that you find their prothrombin time in APTT prolonged with the normal rest of the liver function test. And then we taken the opinion of the hematologist, and those are the patients where the shunt become dangerous because you can land up into problem during surgery and we avoid. I don't know, Biju, what is your experience with this? Because you also do a lot of post-application work these days.
Yeah, so we also do give anticoagulation, but sorry, regarding the workup, we don't do much because we don't end up in any positive results. Even if you investigate them too much also, I think anything is actionable information. Yeah, that's the problem we encounter. You do bone marrow, you do immunoelectrophoresis, whatever it is. Unlike Western evidence, we don't have anything actionable at the end of the day. So you continue to do it, but it will not yield any result. That's what my opinion regarding that. But regarding the anticoagulation, my comment, we do use anticoagulation a little bit more extensively.
Okay.
Also find the aberrations in the INR is little bit more what we expect. That I also fully concur with your views, sir, regarding that. We find more aberrations in INR despite a normal LFT, despite a normal. So the next question is regarding the probably regarding the RUT shunt. What is the best investigation to delineate the left portal vein? And related question is you find it good left portal vein, and do you find it intraoperatively it has blocked the vein? You had any experience in the past like that?
No, see, so I will frankly accept this, that I have never attempted a correction. Okay, so I don't have an experience, but I've analyzed, and Dr. Abedalvi will bear with me because he was a part of the analysis when we published that gastric varices thing, extensive analysis of all the SPGs. Okay, at that time, and retrospectively, I was looking at, there's nothing, means most of the time, this umbilic left portal vein is not patent. Most majority means I have not seen patent left portal vein. Even subsequent to that, even with the CT or MR photogram. So as far as the delineation is concerned, I think CT or MR photogram gives a good delineation of all the intrahepatic and extrahepatic portal venous system. So I don't think there is any other alternative modality which will be used.
One technical question is in DSRS, do you need to ligate the coronary vein?
Yes, you have to. You have to ligate because to make it more selective. So not only the coronary vein, right gastroepiploic vein also.
Okay.
To avoid the ST.
Yeah. The next question is, although you answered, I think the delegate want a clear answer. What is the ideal surgery for NCPH with the large symptomatic spleen? You already answered, but still.
Yeah, I've shown that the large spleen is not a contraindication for DSRS. I've showed the photograph. That's why I showed that particular clipping, that how the spleen shrinks. So this is not a contraindication for DSRS. If at all there is indication the splenectomy is to be done, then I will combine it with my modified Segura operation rather than doing the proximal shunt.
Another question related to DSRS only. Clinic artery, do you clamp, ligate? If you clamp, how long you can keep it clamped?
Okay. as long as you take the time to finish the shunt. So you should ask me that how long you take to finish the shunt. Yes, it is about half an hour or so. So it is not a ligation. It is just either you put a bulldog clamp or snugger around it. It is a temporary occlusion. Because if you don't do that and you have clamped the splenic vein, the spleen will congest and enlarge, and it will come in the way of while doing the shunt surgery. That is the reason we put the temporary clamp. Yeah.
Okay. How often we see hepatopulmonary syndrome after shunt surgery?
Okay. I haven't seen one. I think this was a question raised in one of the group sometime back, and we were looking at the literature that it is said that the shunt surgery can worsen the HPS. While there was another something in the literature where they said that actually shunt surgery takes care of the HPS. So it is I don't think we have a right answer for that.
Do you do on-table biliary bypass and shunt together for portal biliary?
No. I very firmly believe that you have to allow. See, why I don't do? There are two reasons. One, the portal system, when you decompress, this is not just immediately everything, the pressures come down to normal and everything shifts. It takes time for the portal circulation to get redistributed. Second thing, in 70% of the cases, you don't have to do the biliary surgery. And that's what I have shown. And for that, what you have to do, you do the shunt surgery. If there is a stent, biliary stent and all that, you remove it and then observe the patient. If the patient only, if he becomes symptomatic after doing the decompression surgery, then only there is indication for doing a biliary intervention. So there's no point in combining the two.
I think, sir, you made an important point that many of the patients, the portal biliopathy resolves, and the portal biliopathy probably can affect the entire biliary system also. So it's like that you do a dominant stricture, you do a edge, and you're curing the portal biliopathy. It is not so. Do you have any more comments regarding that particular issue, sir?
Yeah. So see, the thing is that I didn't go into details of the this portal biliopathy, how it caused and what are the components. But one has to remember there are two components. One is it is only compression by the collaterals, and that gets resolved with the shunt surgery. The second is the ischemic stricture of the bile duct as a result of thrombosis of the intraepithelial and the veins which are in the wall of this. Now, when that thrombosis happens, it causes a fibrosis. That fibrosis leads to stricture. Once there is a stricture, that will not resolve with the shunt surgery. That will require a bypass surgery. But in that case, the collateral becomes less tense, so the bleeding becomes less on the table.
Okay. The next question is, any incidents of splenic artery injury during the surgical procedure, and how will you tackle it?
Okay, I didn't have a misfortune of injuring the splenic artery, but if it is at all, I think one can do the end-to-end anastomosis. Okay, it's not that difficult. Unless you have caused a lateral tear in the splenic artery. Then it's a different issue.
Sir, will you change your shunt plan? Go to a splenectomy related shunt?
Yeah, so yes, see, the thing is that what you do. Now, if the splenic artery is gone alone and the splenic vein is patent, I will still go ahead with the shunt surgery. Okay. I won't change much of the plan. Because as I've shown that splenic artery embolization is one of the way to treat the hypersplenia today. Okay, do you do spot urine sodium estimation to assess the shunt patency? No, I don't. I don't. Do you do it? Did you? No, we never do, because I think you have better markers for shunt patency on table. See, nowadays with the availability of the Doppler, which you can procure in the theater also, you can show how the flows are and how the patency is. Yeah, and the fall in portal pressure, what is your opinion about that?
regarding the shunt patency?
So I think KM days we used to do it. I stopped doing afterwards because you can make out what the shunt lie and how the shunt size, and if everything is fine, the total pressure will take time to come down. They don't come down immediately. There will be some drop immediately on the table, but it is not that is the final drop. It takes time for the total redistribution.
Okay. Why do
Biju, I will ask you, do you do the total pressure on table?
Yes, sir.
Because you are working in a teaching institution right now.
Yeah, we do before splenectomy, after splenectomy, and after shunt. But as you mentioned, this is more of a academic reason,
Yeah.
and not because we really expect anything out of blue measurements. Yeah, more of an academic reason. So why do EHPO children have more chance of mental retardation?
Of
Mental retardation and EHPO.
mental retardation. Oh. Can somebody, is the one who is asking the question, quote any reference for it? Because I haven't seen. My patients they were children when I started endotherapy for them. Some of them underwent devasculation. They are now adults. They have children. They are gainfully employed in their work. Okay. Some of them are in quite high position. So I haven't seen any of my patients being mentally retarded. And Biju, I will ask you whether you have seen any patients.
Yeah, in fact, many of the EHPO, their mentation actually improves very well over time. We don't have that issue. Yeah. Now another question, I'll just read it. Non-shuntable portospino SMV anatomy in EHPO with a failed endoscopy treatment for portal biliopathy. So there is a failed endoscopy treatment for portal biliopathy, but there is a non-shuntable anatomy.
Okay. Now, yes. So these are difficult cases to manage, and the way to do it, yes, you can attempt a direct surgery. It is hazardous, but that's the only way. I've done few, but there's no way out. Or you have to commit for the lifelong endotherapy.
Okay. So the probably last question is a particular value for omental vein pressure reduction, and how much is reduction is called a good effective reduction? That you already answered.
I don't do it, so I don't believe in that. Yeah.
Okay. These are the questions from the audience, and the last point I wanted to discuss: if we get patients with the pan thrombosis everywhere, in the splenic vein, other superior mesenteric vein, most of the area there is thrombosis. But patients sometimes behave very well, and they present with the intestinal problems later. So, what is your experience, and how do we manage them?
Yeah. So see, these are the patients. Actually, I have some case capsule, but for the want of time, I didn't show them. Basically, see, now here your innovation comes into picture, and you have to look at the whole. If you see the CT photography and analyze which vein you can use it as an alternative, because these are bad situations, right? You won't have a named vein available, so sometimes you can get the IMB, which you find that it is somewhere, it is in connection with the main portal system and can be used for the draining into the renal vein. Sometimes you can use one of the collaterals for this thing. The makeshift shunt comes into picture. Yes, the issue is that whether makeshift shunt remain patent for a long time or not, remain unanswered, because nobody has done the systematic analysis of these cases, because numbers are very small. And whatever I have done, I have found that it remained patent. At least the patient didn't have the further rebleeds. And that's indirect evidence that either there's something has happened which has taken care of it by natural course, or my shunt is still working. So one has to look for the alternatives.
Yeah, I think that answer was very correct. And last month also, the idea is, I think, look for a shuntable vein anywhere. and a shunt, and it's very difficult to create evidence. Last month we had done a first jejunal vein to IVC shunt because nothing else was available actually. 100 everywhere, nothing else was available. So very difficult to create evidence, but since the complication rate is very less, I also follow your dictum of identify any vein and do shunt. And thank you very much, sir, for the extensive and elaborate lecture and clarifying almost 20 extra points as well. And it was a very wonderful talk, and we had a very large audience from India and abroad. Thank you very much. Back to Dr. Biju.
Thank you, Dr. Biju, for conducting meeting so well and asking the relevant questions directed to Dr. Professor S.K.Mathur. Thank you, Mathur sir, for joining. He is right now in America. Actually, he joined from there only. Actually, he has to fly back to India today only. So thank you for joining in the busy schedule. This lecture will be available on the YouTube, and this will be a lecture which will be seen by many aspiring, especially transplant surgeons. Thank you once again. Thank you, Dr. Abel. Do you have something to say, Dr. Abel?
Actually, sir, could you talk on DVASC as the procedure which you taught me how to do it? Because that is another escape route.
Yeah. Abhay, I didn't talk about that devasculation procedures today because the topic was very specific, role of shunt surgery. Yes, for emergency, as you know, that was a preferred choice for me. Basically, it is based on the same principle like the extensive Segura operation, except I modified to the extent that making it more simpler, but keeping those basic principles same. That is extensive devasculation, esophageal transection. Modification was not to do the splenectomy because I don't think it contributes in any way. Rather, it adds to the time and the blood loss. And my philosophy is that no surgery for portal hypertension is 100%. You will have failure, 5 to 6% or 8%, depending on the type of procedure you are doing. And you have to have a plan for the alternative therapy when you face with this. So if I preserve the spleen, and by chance the splenic vein is patent, and this patient after DIVAS, even after 20 years, comes back with the rebleed, you have a shunt, you can fall back onto the shunt. But if you have done the splenectomy, then you have gone out with that alternate option. So that's why I preserve the spleen and do the abdominal approach only, not the thoracoabdominal approach. And that is because once we started doing transhiatal esophagectomy for colon cancer, we realized that you can work transhiatally and mobilize the esophagus right up to the inferior pulmonary vein. You don't have to do the thoracotomy. And today I'm sure that with the expertise laparoscopic with BIJU hair and PROF.BIJU and robotic surgery coming into picture, perhaps there will be time when you will be doing the shunt surgery and the devasculation surgery with the robotic, using the robotic or laparoscopic approach. And I'm sure that you have that expertise, you will be able to do it. And that will revolutionize the whole surgical approach to the portal.
I will not do it, but sir, it was something which was wonderful, which has been published, and people should know that trans-abdominal extensive devascularization of the stomach and the esophagus was published by you in British Journal of Surgery, and people would know that that is a much simpler operation than the vascular anastomosis that comes into picture. So my hats off to you, sir. Thank you.
Thank you, Abhay, for reminding that. Yes, actually, I designed it, as you know, that for a general surgeon who is not well versed with doing the shunt surgery. And even at the district level, one can do that operation because you don't need any vascular instruments. You only need, if you remember correctly, the right angled forceps and the linen sutures or the silk suture. You don't need any fancy sutures for that.
Yes, sir. As assistant professor of yours, I've done many of these and we had got very good results about it. So thank you for that. I just want to give it to the crowd that there is alternate procedure than the shunt, which is very complicated, which has been designed by sir, and I was one of the party to it. Thank you.
You had been party to all those publications, Ravi. You had been means contributors to those innovations.
Thank you, sir.
Thank you once again, Mathur sir, and thank you, Biju, for moderating. If you have any final words, you just say and we can wind up.
So my final word, as far as concerned, I'm thankful to both the BIJU and BIJU. I told you, both of you, that how I used to get confused between two of you, which is where I put at the A and where I don't have to. But today, I saw you when I was getting your messages and everything. I made it a point that I registered correctly and don't make a mistake of calling you in the reverse way. But yes, I think what you are doing and you have done so far for the education of the surgeons, I think it is a tremendous work. Okay, it's a very commendable work. Let me put it this way: very commendable work. And I'm sure the ASI will take note of it and will definitely honor you with something, especially with Abhay Dalvi present here. I think he should look into that. That's my wish, and I'm thankful to you for giving me this platform to interact with the people.
We are really honored to have you in this platform, sir. Thank you so much.
Thank you.
Biju will wind up.
Yes, please. Thank you.
Thank you. Thank you.
Thank you all. Thank you, Abhay, for those kind words throughout.
Thank you, sir.
Should I disconnect myself now, Biju?
Yes, sir.
Biju?
Please.
Yeah. Thank you.